Hello and welcome to the channel, and this is Dr. Prashant Shukla, and today I am going to demonstrate a case of a 65-year-old female patient who was known diabetic and had this soft gummy diabetic cortical cataract. I had few issues during the surgery, and I'm going to demonstrate how those problems were solved. By this time, one side port has been made and one more side port is being made. As it is evident in this case, due to diffuse cortical opacities, it was very difficult to visualize the entire capsule regardless after staining. So I have just switched on the retroillumination mode of the Lumira eye microscope, and now it is still better and we can visualize the entire capsule. And here I am using a 26 gauge bend needle cystitome to raise a flap, and I am gently guiding the flap to initiate a capsular access. As the cataract is gummy in nature and it is a relatively soft nucleus, so it was slightly difficult to do it through a bend needle cystitome as the flap was not moving as intended. So here I am using a micro capsular access forceps, and in spite of the retroillumination mode and the capsular staining, I am finding it quite difficult to actually visualize the rhexis where actually it is going. Still I am doing it very slowly, and towards the end there is a rhexis extension at around 3 o'clock, and from here I am not able to actually see where the flap has gone. I am trying many maneuvers, but it is very difficult to retrieve the capsular access back, as probably it has gone up to the equator. Here again, after refilling the antechamber with viscoelastic, I am trying the Little's maneuver so as to grab the rhexis edge and get it back, but all my efforts are going in vain. So I have decided to cut this flap and make it slightly regular using a micro scissors through the side port. Whenever we have these dense spoke like cortical opacities in the cataract, there are all the chances of losing the rhexis, and the rhexis can go to the periphery. So one has to be very careful while performing rhexis in these kind of cataracts. So after evaluating the situation of the capsular rhexis, things are going in my head whether I should be continuing with phaco emulsification or I should be converting it. So I have decided to convert this case because I am not able to visualize the rhexis margin at 3 o'clock, and I don't want to make things more complicated in this case. So after removing all the anticapsular remnants, whatever they are in the antechamber, so I am going to convert this case, and I am going to do a temporal manual small incision cataract surgery using a Westcott scissors and a forceps. I'm making a conjunctival peritomy at 3 o'clock. Mild cautery is then applied to uh, get rid of the bleeding vessels. Mild cautery is usually applied. I am not going to charge the sclera with excessive cautery. Now here, using a 15-degree lens tip blade, I am going to make a frown incision about 6 to 6.5 millimeter in breadth. Now with the help of a crescent blade with bevel up, I am just going to mark the ends of the incision and make a tunnel. Well, after marking the ends of the tunnel in a single plane, the blade is now going to be progressed into the cornea to about 1.5 millimeters, and the funnel shape incision is going to be extended on the both sides, left and right. A funnel shape incision with a good valvular effect is being created with slow wriggling motions. The blade enters the corneal stroma and it is now being extended on the other side. Well, apologies for slightly offset microscope. Now it's better. As told by the assistant, the centration was then corrected. Completing the funnel shape incision, now is the time to enter the entry chamber with a 2.8 keratome, and the inner lip is open while moving forwards. Care is to be taken that we have an inner lip which is almost parallel to the limbus. Now again, switching on to the retroillumination mode, I am going to do a very gentle hydrodissection using a 27 gauge cannula mounted on a 2 cc syringe. The nucleus is slowly tapped. The mobility of the nucleus is now being checked. I am purposely avoiding the hydrodissection just opposite to where the rexus went off. Some more viscoelastic. Now with the help of a Sinskey hook, the nucleus is gradually dialed up into the entry chamber. Here it is. Till now everything went on very smoothly in spite of the rexus run out, and now the actual problem starts. As soon as I am filling the entry chamber and the posterior chamber, and suddenly the iris starts prolapsing out from the main incision. I am trying to deposit it back, and this is my attempt to remove the nucleus, and suddenly the vectors get holds of the iris and the problem starts in the surgery. Now I have a big problem. The whole iris is prolapsing out from the main incision. The big nucleus is still in the entry chamber, and the iris is behaving in a very bad way. The floppiness is well marked and can be seen. Some more viscoelastic is injected and I am trying to do a visco aspiration of the nucleus. Still I couldn't do it. The nucleus got stuck into the tunnel. Again the nucleus has been pushed back and things are becoming even more difficult to manage now. The iris is becoming more and more floppy with each attempt of my repositing it back. Putting some more viscoelastic to protect the corneal endothelium. Now the iris is out. Now what to do? Now I have my plans to remove this nucleus by sandwiching it between two instruments, but before that I need to extend the wound because I don't want the nucleus to stuck again, and here I am extending the wound on one side. Now putting some more viscoelastic to protect the corneal endothelium, and now I am going to use a Sinskey hook and a vectis behind and Sinskey hook in front, and using the PHACO sandwich technique I am going to sandwich the nucleus in between without touching the iris or the corneal endothelium, and the smooth delivery was conducted through the main incision. Still the problem is not finished. We have the problem of floppy iris. The lens has to go in. We have to get back this iris back into the eye. Now I am depositing the iris back using an iris spatula, and now I have taken the irrigation handpiece of the bimanual irrigation aspiration and I am just flushing out the cortical matter and the residual epinucleus, whatever debris is left into the entry chamber just by irrigation. Still the iris is coming out again and again. With just the jet of the fluid, what maximum debris cortex I can remove, I am trying to remove it. Now as can be seen, we have got a small chunk of cortex left at around 9 o'clock, but now my plans are different. I am going to implant a 3-piece intraocular lens into the eye. I am purposely avoiding a single piece because of the rexes run out, and here goes the 3-piece intraocular lens into the eye. I am purposely avoiding to touch the iris, and it goes into the capsular bag. Now with the help of a Sinskey, I am engaging the optic haptic junction and just dialing the lens into the capsular bag. I am going to remove the cortex after the implantation of the intraocular lens. Now using bimanual irrigation and aspiration, I am going to remove the viscoelastic and the residual cortical matter which is there in the eye. The bottle height is kept low and I am using a very low vacuum because I want a low pressure surgery to be performed. The vacuum is about 250. Bottle height is around 75. Slowly the cortex, whatever was left, is removed. Switching hands and trying to grab whatever cortex is at 12 o'clock. Now there is a sigh of relief that we have a lens inside the eye. All the cortex has been removed, viscoelastic has been removed, but still the problem of floppiness of the iris prolapsing out through the main wound has to be taken care of. After removing the cortex, I am going to constrict the pupil. I am using pilocarpine intracameral, pushing the iris back, injecting some pilocarpine through the main wound also. Through the side port, I am injecting some air and waiting for the pupil to get constricted. Now here closing the side port, because it's always a good idea to have a closed chamber with very less leakage of fluid. And now is the time to get this iris back into the eye. With slow movements, I am gently pushing the iris back into the entry chamber. Still it's not that very easy, because the iris has suffered quite a bit of trauma with the irrigation handpiece, nucleus delivery, lens manipulation, multiple attempts of getting this iris back into the eye, multiple attempts to deposit it back. The iris has certainly had many trauma to its structures. Now the final try, I am using a Sinski to get this thing into the eye, and finally I am successful in getting the whole iris back into the eye. I have put in some air to form the entry chamber, some more of pilocarpine to constrict the pupil, and now is the time to close the wound. Here I am using 10-0 nylon sutures. I will be using multiple interrupted 10-0 nylon sutures, because I do not want to take any risk of any iris prolapse through the main wound in near post-op period of the patient. Here I am putting a 8-0 vicryl suture, because the iris was prolapsing out through this area. 8-0 vicryl is slightly thicker than 10-0, so it will take care of the prolapsing iris. Here I have put almost 3 to 4 interrupted sutures, and hopefully the iris will not come out in the immediate post-op period. Well, now is the time to close the conjunctiva using 8-0 vicryl suture. Proper closure is very important. The patient did very well in the post-op period, and as the surgery was done through a temporal incision, and the patient had a pre-existing against the rule astigmatism, and to my surprise the post-op visual acuity was very good, and the patient had just minus 0.75 dioptric cylinder at 170. The patient was very happy. So we all encounter these kind of problems during our surgery, and we should not panic. We should all have myotic agents like pilocarpine or carbachol in our OR, and things are really difficult to manage sometimes, but one should keep our cool and try to manage the case with our patients. And hopefully this video is going to help you in your academic learning, and thank you so much.